Okay, so to begin with, thank you IAP NEOCHAP for giving me an opportunity for talking about therapeutic hypothermia. So in next half an hour, what I'm going to talk about is this is the outline for it. We will talk about definition of HIE in pathophysiology. What are the criteria being used for therapeutic hypothermia and little background about that. When to do cooling and what is the evidence has been for the cooling. How to do cooling. We will talk about a little bit about the cooling equipments in India. And we will also talk about the Helix trial, which we will discuss, and then what has been the NNF positional statement after Helix trial. So let's start with what is HIE? HIE is a common cause of neonatal encephalopathy. We know that most common cause of death and serious brain injury in the term infants, which is affecting at least 1.2 million infants globally every year. And out of which 96% of this occurs in the low and the middle income countries, okay, which we are aware of. Now, till date, there has been not till therapeutic hypothermia came, there was only a conservative treatment for hypoxic ischemic encephalopathy. But there were a lot of data came from high income countries in year 2000 and that they suggested that therapeutic hypothermia has been very revolutionary treatment in preventing death and disability and reducing, and that was proved by number of trials. Okay, so data from HI suggested that death and disability is reduced at 18 months by therapeutic hypothermia. So to know what is actually neonatal encephalopathy, it is defined very, it's a lengthy one. It's a clinical syndrome of disturbed neurological function in the first week after birth in an infant which is born at or beyond 35 weeks of gestation, who manifest by a subnormal level of consciousness or seizures, often accompanied by difficulty with initiating and maintaining respiration, depression of tone, and reflexes. Now, it has been cited that one of the most commonest cause of neonatal encephalopathy is a hypoxic ischemic encephalopathy. So, what is perinatal asphyxia or birth asphyxia, which was used previously? It results from the inadequate intake of oxygen by the baby during the birth process, which could be before the birth, during the birth, or just after the birth. So, little bit of expanding. Hypoxia is a partial or complete lack of oxygen in the brain or the blood. Okay. So when your baby is not getting oxygen or deprived of oxygen, that is hypoxia. What is asphyxia? It is a state in which placental or pulmonary gas exchange is compromised or it ceases altogether. Then what is ischemia? So ischemia, as we know, the reduction or cessation of the blood flow to an organ which comprises both oxygen and substrate delivery to the tissue. So when you don't get oxygen, that is hypoxia. When you don't, there is a cessation of blood flow, that is ischemia. And what is hypoxic ischemic encephalopathy? It is an abnormal neurological behavior which results in the neonatal period arising from the hypoxic or ischemic event. So that is the brief explanation of hypoxic ischemic encephalopathy.
Jatin sir.
Yeah.
There is a request from the participants that voice is slow. So can you be more loud?
Okay.
Yeah.
Is it completely not audible?
No, it is audible, but the voice was little bit slow. I think now you are loud, I think.
Okay.
Yes.
So as I told, hypoxia is something which is not enough oxygenation. Ischemia, which is not enough blood circulation. And as a result, what we get is an encephalopathy, which is we define as a hypoxic ischemic encephalopathy. So going into a little bit of pathophysiology, as we know, on the left side, you can say when there is a hypoxic ischemic encephalopathy injury, when the baby does get hypoxia or ischemia, there is a series of the events will happen, which is within happening in the minutes, which is a primary energy failure. There is a low oxygen, there is a low glucose, there is a less blood supply, there will be an anaerobic metabolism, there is a reduction in the ATP production, and there will be high lactate. This will all lead to cellular injury, which will happen in the minutes. Okay, so this primary energy failure within few times after an hour, which will be followed by something is reperfusion. Okay, there will be re-establishment of the circulation, and this latent phase is very important when there is a reperfusion. Okay, because after latent phase, there is a secondary energy failure in which there is a cytotoxic edema and then cellular apoptosis. So if we have any intervention which has been taken in the latent phase in reperfusion injury, then there are chances that we can prevent the secondary energy failure, or we can prevent the cytotoxic edema and cellular death, which is following latent phase. So here there is another way of presentation. There is a hypoxic ischemic encephalopathy followed by depletion, which led to primary neuronal death. And if you have a something here, so the evidence suggested there is if you induce a moderate hypothermia, which is between 33 to 34 degree of centigrade, and you induce that, it will lead to prevention of the secondary neuronal damage, and it will reduce the apoptosis with a programmed cellular death. Okay. So how does this cooling work? So it reduces the cerebral metabolism. It will prevent edema. It decreases energy utilization. It reduces and suppresses the cytotoxic amino acid accumulation, which is actually a part of secondary energy, secondary phase. Inhibits the platelet activating factor. It will attenuate secondary neuronal damage, and it will lead to cellular death. It reduces the cellular death, and it reduces the extent of brain damage, and it will prevention of the blood-brain barrier disruption. So there are multiple mechanisms why therapeutic hypothermia in a moderate degree will prevent the brain injury. So by lot of researches, evidences, RCTs, and systemic review, it is proven that. How do we induce? So to induce, you have to stabilize babies to moderate hypothermia. Moderate means you have to keep a body temperature between 33 to 34 degree stable. It has to start before 6 hours. So you have a 6 hours of therapeutic window when you can induce therapeutic hypothermia to the baby. You continue it for the 72 hours, and there will be a progressive and the cautious rewarming, gradual rewarming over next 12, 24 hours, and that is the completion of the therapeutic hypothermia. So yeah, body temperature will 33 to 34 degree, 72 hours. It will reduce the metabolic, it will cause metabolic slowdown, and eventually there will be recovery. Okay, so who are the candidates? So a lot of studies have defined it is only beneficial to the babies who are more than 36 weeks of gestation, who have hypoxic ischemic events. The baby's weight should be more than 1.8 kg. You have an ability to start therapeutic before 6 hours, therapeutic hypothermia before 6 hours after birth. That is the time. And you have to have an evidence of hypoxia, ischemia, and encephalopathy. If you fulfill this criteria, this baby can benefit from therapeutic hypothermia. So there were, how do we define the baby has got hypoxia, ischemia? So there are number of criteria, number of studies have different use. This was taken from Toby trial, which was a very popular Toby trial in European countries and UK. So according to that, there is a criteria A. Criteria A means this baby has an event which led to hypoxic event. So how do you know this baby had an hypoxia? So you got to have a cord blood gas, or you have got to have a blood gas within the 1 hour of life. If your pH is below 7 and your base axis is more than minus 16, that does suggest that this baby had an hypoxic event. Suppose if you don't have this, you need to have something way of presentation could be an Apgar score. So if your Apgar score less than or equal to 5 at 10 minutes of life, that does include that this baby had sufficient hypoxic ischemic events. And third, if you don't have that much as well information, you can use another criteria, which is known as a continued need for PPV or intubation at the end of 10 minutes. So after 10 minutes, you need have PPV. That means there was a sufficient hypoxic ischemic injury. So that will full. So how do you think about at this point? You can see that this baby had an acquired hypoxic ischemic event. Then it comes to criteria B, which means that this baby had, now we know that there was hypoxia ischemia, but how do we know this baby is going to have encephalopathy? So you need to have some neurological criteria. So in terms of any abnormal sign, like maybe I've got an irritability, maybe had an abnormal state of consciousness, maybe is drowsy or very hyper alert, seizures, abnormal tone, or there could be an abnormal reflexes. Any of this, if baby fulfills within 6 years, that means that this baby has got signs of encephalopathy, and you can consider this baby for the therapeutic hypothermia. Now, there is another criteria which is abnormal cerebral function monitor, which has been actually optional criteria in Toby as well, but most of the units in the UK were using cerebral function monitor. So, which is a handy device actually. We can't talk in this lecture about it, but I will just brief you. in a couple of slides. For neurological criteria, you can also use the various scoring system. As we know Thompson's scoring system, where we use various neonatal reflexes and consciousness status of the baby, and we can classify that this baby has an acquired how much of the neurologically mild, moderate, according to the scoring. There is another popular system, as we all have heard about it, which is a Sarnat and Sarnat modified Sarnat and Sarnat classification. In also this, you also classify on the basis of your vital signs, your complex reflexes, neuromuscular control, and level of consciousness. And depending upon that, you can classify as a stage 1, stage 2, and stage 3, which is the hypoxic ischemic encephalopathy. So these two criteria will tell you that this baby has acquired an hypoxic ischemic encephalopathy, or the features of that, and that you have to define within the first 6 years of life. So what is CFM? I just said about this. So basically, it is a amplitude integrated amplitude EEG. So it is used as a eligibility to start cooling in many centers. So when you are not sure about neurological criteria, it is a very handy tool. You can apply electrodes in the baby's scalp. It can detect subclinical seizure activity, and it can also give you the background neurological encephalopathy grading, whether this baby is neurological. It basically works on a raw EEG, and it is being compressed, and it is being converted by a semi-logarithmic formula into a trace, and that is give you what is the background, and then you can classify encephalopathy on the basis of amplitude EEG. It is very also useful for the long-term prognostication. So suppose if baby had a severe encephalopathy, and if you see that by therapeutic hypothermia, within 24 hours you get a better sign, that helps in the prognosis of the baby. So it has got a diagnostic value as well as prognostic value, and together with the clinical examination, it is highly predictive of neurological outcome. So this is the trace, and there is a classification. There is a pattern classification and alternative classification. You can see that how does it look. This is the different types. We won't go in the details of that, but on these patterns you recognize. Once you see start using this, you will more and more recognize what is the pattern, and you can use in the practice as well. So we heard about cooling, but why to cool? Does it work? So actually, there is enough evidence from the various randomized control trial, meta-analysis, and the Cochrane review. And this level of evidence is very high. It is, you can consider this very equivalent to antenatal steroids used in the premature delivery, or surfactant used in the preterm. It is a very standardized treatment in the Western world. It is a standard care for treatment in all resource-rich countries. So what was the evidence? So there were a number of trials between year 2000 to 2012-13, and then there was this big systemic review published on the Cochrane, that is the cooling for newborns with HIE, and this was a this summarized 11 randomized control trial, which included roughly about 1,500 infants who were included in the study. So this was clearly suggestive of benefit. So look at that. The primary outcome was to look at the death and severe disability at the 18 months of age. Okay. So there were two arms. You can see the major trials were like NICHP trial, TOBI trial, PULCAP trial, ICE trial. So there were a number of trials were included, and it clearly showed. You can see the forest plot. There were all the trials were suggestive of there is a definitely favoring. It was favoring the therapeutic hypothermia arm, and this was by standard trials, which was very highly high quality trials, and this was proved. So this systemic review is not only looking into the primary outcome, it looked into the number of secondary outcomes as well. It looked that what is the effect on survival with the normal neural age. This was another actually systemic review, which was also done by Professor Andrew Whitlow. And they also showed that there are these trials also favoring the outcome in therapeutic hypothermia. Okay, so there was a subgroup analysis whether do they this systemic review tried to classify them into moderate encephalopathy and severe encephalopathy. And they clearly showed that babies who had a moderate encephalopathy got benefited, and babies who had severe encephalopathy, they also got benefited by therapeutic hypothermia. So that was this was the first plot for that analysis as well. Even there was an effect on major disability. So if you see that there are about number of 30, 34 outcomes have been studied, and most of them got benefited by therapeutic hypothermia in this systemic review. So you can see that. Okay. So this is just a line about optimizing cooling trial. Actually, what happened is this was a standard. All the cooling trials which we talked about, they use 72 hours and 33 to 34 degrees. But NICHD also did one actually trial in which they had four groups where they had a 72 hours 33.5 degree temperature and 32-degree temperature. And there was a prolonged cooling as well, where they induced both ranges of temperature for 120 hours. Actually, this trial was stopped prematurely when there were 364 babies were recruited and enrolled out of 72 because of the safety and futility result. And it was found that there is no much difference. There was no any difference by doing a deeper cooling or prolonged cooling. And it was quite useful to get the information why we cool for 72 hours only and why not more than that. And why to 33? Why there is a moderate hypothermia only? In fact, severe hypothermia can cause induced damage rather than that. So 33 to 34 degrees is the optimal temperature. So this was about the Western world. Can we extrapolate this baby's results into our Indian settings and can we adopt therapeutic hypothermia? So before that, we need to consider what is the safety of cooling. Is it really effective in our setting as well? And is it feasible to do also? So in those years, there were a number of trials happened in India as well, actually. And if you see, there were all the trials, they use a low cost cooling device in terms of they use a cool gel, there was a phase changing material, there was some water bottles and different trials were used. And there was some definite benefit out of that, but still there was not a servo control device used on this. Following which, there were more studies were done in the subcontinent as well in LMIC, and Helix trial was conducted in 2015 actually to 2019. So, but before that, there was an evidence that the cooling does work with the even low cost devices, and it was showing to be beneficial. So there was a systemic review actually, which was included many studies, and it also found that that cooling has been useful in LMIC. This systemic review was done for specifically for the using low technology devices actually, and this showed that there was a clear this outcome was also favoring the use of low cooling devices. Still, therapeutic hypothermia was beneficial. So actually, this was interesting. There was a summary of the all randomized control trials from LMIC. So low and middle income country had the number of trials prior to Helix trial, and there was a systemic review, and majority of showed that there is a benefit. The forest plot was saying that it was favoring the therapeutic hypothermia arm, and this were all done between 2003 to 2020 actually. So this was also quite encouraging that there has been a beneficial effects of therapeutic hypothermia. So how do we cool actually? We talked about the evidence. So how do we cool actually? So for cooling, there are two. We have heard about selective head cooling and total body cooling. So which do we go for? So when the trials began, it started with cooling, head cooling as well. It was like, as I showed in the picture, there was a cooling cap and body was being warmed with a heater. So there was fewer side effect of cooling. But there was a significant difference, maybe up to 6 degree difference between superficial and the deeper part of the brain. Okay. And compared to whole body cooling, there was a 0.6 degree difference. So it's a quite significant. And there were concerns raised that deeper brain may not be adequately cooled with this method of cooling. And then after therapeutic hypothermia was done in the form of total body cooling, which was used a cooling mattress, which was more widely used, a better temperature control, and there was only the concern that there were increased side effects of therapeutic hypothermia in this. So if you have a critically ill baby with the HIE, if a baby is more than 30 weeks, 36 weeks, is still requiring resuscitation at 10 minutes of age with altered consciousness or a tone, stop actively warming the baby by switching off the overhead warming. That is the passive cooling. Okay? You can alert your NICU and request an open pot. You can do amplitude EEG if you have, and you can prepare for a cooling mattress. Okay. On arrival to neonatal unit, give no supportive heat measures. Don't switch on the warmer. Consider that baby is for therapeutic hypothermia, and rectal temperature should be measured because you go for core temperature and apply cerebral function monitoring. And you commence active cooling as soon as the decision is made based on your clinical findings. So cooling is being done in the three phases. There is an induction phase, which is being rapid cooling to 33 to 34 degree, which is being 35 to 40 minutes, 30 to 45 minutes. Then there is a maintenance phase, which is 33 to 34 degree, which can last for 72 hours. and there is a slow rewarming. So you gradually rewarm 0.5 degree per hour, and you can go for 12 hours, and you can watch out seizures during this phase. Okay, so cooling is being conducted in 3 phases, which we need to know about. So this cooling process, you can prepare a bed, you can attach cerebral function monitor, you can attach rectal probe, prepare mattress or cooling devices. Okay, then attach other monitoring. Attach cooling device to the baby. Target temperature should be 33 to 34. There should be continuous recording of the temperature, rectal temperature, and then you, as I said, gradually revolve. So the practical tips: single cotton sheet between baby and the mattress you can put. Rectal temperature probe 5 to 6 centimeter depth of continuous core temperature. Monitor vitals, blood pressure, saturation, surface temperature. Heart rate will be low in the cooled baby. They can go up to below 100 as well, and maybe around 70 to 80. Blood gases can be monitored. You can use sedation or pain relief because cooling can be a painful experience for the baby. Watch for the bleeding and subcutaneous fat necrosis. Actually, subcutaneous fat necrosis is one of the well-known recognized complications of the therapeutic hypothermia. Even therapeutic hypothermia can aggravate your pulmonary hypertension. So you have to be very careful in using therapeutic hypothermia as a baby with the pulmonary hypertension. So this is the just a quick picture of a baby who is ventilated, who has got therapeutic hypothermia. There is a servo control machine. There is a amplitude EG is going on as well. So that is it looks like something like this. So what are the cooling devices we have? So there are full body cooling device which is servo control. There are full body cooling which is manual control. There's something phase changing materials PCM, and there is cool caps, and there are some traditional ways of like water bottles and ice packs can be used as well. So there has been comparison of various devices. Actually, this is a high-tech cooling devices which has been used in the Tachytherm and the blanket roll and pretty cool is there, servo control is there. They all are very good in rewarming. There is a very in induction phase. They quickly cool the body and they sustain temperature for longer time and without much fluctuations. This is the low cooling, low technology cooling devices, which is like which you do natural cooling or water bottles, or you can use fans, gels, and phase changing materials. Okay, and you can see induction time has been 1 hour or within 1 hour in all of these methods as well. The These are the some pictures of the cooling devices. You can see out of this, the one of it, there is a phase changing device. Another ones are servo control devices. One of the device lower side, it has got a CFM facility within the device itself. So this is important because this is the comparison of 3 devices. So the topmost is a full body cooling, which is servo control, then manual control, and then selective head cooling. So look at the straight line in the first graph on the top graph. There is a continuous nice control between 33 to 34 degree. Okay, and you achieve the target temperature, it maintains that. Well, if you see manual control, there is a variation between the temperature range. And when you do selective head cooling, there is a more range. So you want it to be like the first graph where you want it to be the straight line where you maintain the target temperature, and this was proven that. So suppose if you do it by the gloves, so you can see that how much fluctuation you will get. Okay, so there is a lot of fluctuation with when you don't use the servo control devices. So this is just a slide to share that. So when you, this is a comparison of actually how does the cooling devices compare, and actually these are 3 different devices. Frozen gel packs, which is a one of the older way of doing it. Then phase changing material, and this there is a servo control device. So if you look at the time taken to cool in Toby trial, there was 30 minutes only. In NICHD trial, it was 90 minutes. Okay, so they are servo control devices which are very good to bring down the temperature. Even you can see that the temperature is maintained for a long time. However, there is a significant difference. There is a significant high risk of subcutaneous fat necrosis, and that is with the frozen gel packs. Okay, so when you don't use the proper cooling devices, it can lead to a lot of complication, particularly even if you look at temperature readings outside the temperature range, it was 9.8% in the frozen gel packs. So servo control devices are always preferred. They give a stable temperature control. They maintain on that range without fluctuations. So this was about how do we use cooling, but we heard about the Helix trial. So in 2005, this Helix trial, because all Indian trials which were done with the low tech devices, then there was this was a one of the trial which was conducted for 4,008 infants with moderate to severe HIE. It was a multi-centric, out of which centers in 5 centers were in India, Sri Lanka, one center, and Bangladesh also. They were all done in tertiary centers. Okay, actually they all use the servo control devices, and there was a very rigorous follow-up of this babies. They had a neurodevelopment, and their MRI findings as well were noted in this trial. Okay. However, the results were surprising. The primary outcome was death and moderate disability at 18 to 20, which showed that there was no difference. And in fact, it showed that there is a higher death rates in the cooled infant. Okay. So that led to a lot of controversy, and therapeutic hypothermia, it was concluded that therapeutic hypothermia should not be offered as a treatment for hypoxia encephalopathy in LMIC, which is low and middle income countries. So following that, in October 21, NNF came up with the positional statement and guideline for use of therapeutic hypothermia, because it was very much required whether it should be used or not following the Helix trial results. And what they did is they did a review of 24 trial, out of which 7 were in higher income countries and remaining 17 were in the lower income countries. And following which NNF made up some guidelines and they came out with the recommendations. So what NFNF recommendations came that it should be used only in level 3 or level 4 NICU where there is a facility for cooling. There should be adequate personnel, neonatologists or nurses. Even if you are using low-tech devices, there should be 1:1 nursing for that. The equipment should be cooling machines, preferably servo control, they said. There should be EEG and MRI follow-up as well. Follow-up cooling criteria, they should use a blood gas should be used, 10-minute Apgar scoring should be taken in the picture, and there should be an evidence of encephalopathy. It has to start within 6 hours of birth, and there should be a written parental consent for that. And prefer the servo control cooling devices. So NNF came up with the guidelines, which has been very handy and useful. So to summarize, I will quickly say HI is still a major cause of neonatal morbidity and mortality. However, it has been well proven that therapeutic hypothermia is one of the most effective and proven therapy for hypoxic ischemic encephalopathy. There are challenges of using cooling in resource limited settings. Okay. However, it should be used practically only in the tertiary center with servo control devices. I think I'll sum it up with thank you for listening to me.
Thank you so much, Dr. Jatin Bhai, for masterly summarizing the elaborative and big topic in a very short time of 40 minutes. I hope you prepared the presentation for 1 hour, but we made it short in 30 to 40 minutes because of we had to accommodate panel discussion also. We can take 1 or 2 questions and then we can go for panel discussion.
Sure.
So the first question is, how does it matter whether it is LMIC or resource-rich country when it comes to cooling? This is the question. I think you have already answered, but can you briefly summarize that question, Dr. Jatin Bhai?
Yeah, basically, see, it doesn't matter. We in LMIC cooling can, because the babies are going to be same everywhere. Okay, so if they get benefit in HIC, they should get benefit in LMIC. The thing is that we need to get the right information. For if you see that in LMIC, in HIC, you get a cord plus gas, you get information on babies, you get the right cooling devices. So if you have got the same, that is what NNF said, that in level 3 or 4 unit, you have got an adequate nursing ratio, you have got a servo control machine, and you have got a facility for follow-up and MRI, and you can get a developmental follow-up. There is no reason I can see why you cannot use cooling therapy for a hypoxic ischemic encephalopathic baby in LMIC as well. So that is the answer.
Yeah. Perfect. Thank you so much. I think we can take only one question.
Sure.
And now we will switch to panel discussion. So I would be sharing, I request Dr. Jatin Bhai to stop sharing so that I would share my screen for introduction of our moderator.